Hi there. Thanks for watching this. Since the onset of the pandemic, we've been seeing increased discussions about how certain groups are being disproportionately affected by COVID-19. Today, I want to talk about the health disparities we're seeing in the African American community. But before we get started, I'm Brianna Baker, and I'm an intern with the Research to Policy Collaboration. And I'm here with my colleague, Nicklin. Nicklin, would you like to introduce yourself?
Hi, I'm Nicklin Charlo, and I'm also an intern with RPC.
And we're here today with Dr. Kamila Alexander, who's a professor at Johns Hopkins University. Dr. Alexander, would you mind briefly telling us about your research area?
Sure. So I'm an assistant professor at the Johns Hopkins School of Nursing, and my research is focused on the effects of intimate partner violence on the sexual, reproductive, and mental health of adolescents and young adults, primarily those living in urban areas and focused on marginalized populations such as Black Americans and those identifying as Latinx.
Well, thank you. We are so glad that you're here today, and we're really excited to talk to you about this pressing issue. So to get us started, could you tell us about the health disparities we're seeing in African Americans amidst COVID-19?
Yes, so there's been disproportionate numbers of infections as well as those that are dying from COVID-19 in Black communities across the United States. In fact, there are 3 times the number of infections compared to white Americans in the Black community, as well as Black people are 6 times more likely to die from COVID-19. You can see that it's creating a really disproportionate burden on the health and the ability to obtain optimal health for families and individuals that are considered Black Americans. So this is really varying depending on the area of the country that people are living in. However, no matter which part of the country you're in, we see that there are larger numbers of Black Americans that are getting sicker and they are dying at faster rates. There are also higher rates of hospitalizations. They're finding that Black Americans are arriving later to healthcare facilities. So the disease has progressed at a greater rate by the time that they actually arrive, meaning that they're more likely to be at an advanced disease state. And once they get there, they're going right into the ICU, right to ventilators. And so we know that once a person is placed on a ventilator, it is a harder road to recovery. Compound that with a potential for having other underlying morbidities, such as cardiovascular disease, diabetes, asthma, and that compounds the trajectory of the illness. Now, there's different hypotheses about why Black Americans might be arriving to healthcare facilities at the more advanced disease state. So Black Americans are more likely to be frontline workers, so they need to work. They also are more likely to live in poverty and not have as many options for transit. We also know that there's underlying racial bias within the healthcare system that can preclude quality care and direction and guidance about when is the best time to actually seek care when you have symptoms of COVID-19. So often they're being told to maybe monitor symptoms for longer or not being offered a face-to-face appointment for adequate diagnoses and screening. So there's a myriad of different things that are happening that are creating health disparities that we're seeing.
Thank you. Are there any subgroups of this population that are especially affected? So like children or the elderly, or are they all kind of affected equally?
Well, the elderly are by far the highest risk population within Black populations that are in the United States, just simply due to physiological fragility, more likely to have underlying health conditions. But we're also finding that a new study just came out that showed that there are younger people, younger adults, between the ages of 25 and 35, 25 and 44, that Black Americans within those age groups are by far dying and having greater infections than their white peers. Well, I'd also say that Black Americans that are living in poverty are also at higher risk for having poor health outcomes. And that's not, specific to COVID-19 necessarily. There's been many studies done that show that, your economic status predicts your ability to stay healthy. Having access to, good nutrition, places to buy healthy foods, ability to exercise, all of those things come into play in being in a healthier state from the beginning.
So you mentioned a lot of those kind of underlying reasons for why we're seeing these disparities. Were there any others that you wanted to mention? I know you mentioned poverty, racial bias, access. Are there any other social determinants of health that may be a reason why we're seeing these disparities?
Well, I mentioned that employment is a huge predictor of being able to stay healthy. In this country, employment is tied to insurance status, so health insurance. The large numbers of people who lost their jobs during this COVID-19 also lost their health insurance. And because, due to historical and contemporary injustices, such as racism and discrimination, Black people are more likely to have employment that does not already have benefits and or are in lower paying jobs. They're also more likely to lose their jobs or their income because of that status. So we know that even in good economic times, Black individuals have higher unemployment rates than white individuals. And that's due to limited educational opportunities and other structural issues within the employment process that disallow Black Americans from obtaining a living wage. Or, some studies that have been done that show that if you have a Black sounding name, you're less likely to be employed. Usually you could be the last hired and the first fired. That phenomenon exists as well. Also, great attention to the fact that because jobs tend to be at a lower wage, you may be unable to afford a car, which means that you're going to have to take public transit in order to get to a job if you were able to keep it during COVID, which increases your exposure. The other thing is that many of the lower paying jobs that we're seeing Black Americans maintain, even during COVID, require regular interaction with the public. So the grocery store clerks, the nursing assistants, nurses even, and only 1 in 5 has an occupation that permits working from home. Another thing is financial strain overall within the family unit, within the environment, due to other historical practices such as redlining that dictated where Black families can live. There's contemporarily our cities are residentially segregated. So Black families have fewer opportunities to live where they want to live and in a healthy community. And because so many of us have limited educational and employment opportunities, we're also less likely to live in our own our own home. And if we do, we also are more likely to live in a multi-generational household, as well as potentially, with multiple families in order to make ends meet. That family structure with this infectious disease creates opportunities for more infections within the household. Black families are less likely to have the wealth that white families have to fall back on. So those families that lost jobs were less likely to have the cushion that they need. So that makes for a really stressful household and can really exacerbate already, dense housing, high crime, and just poor access to things that can continue to make you healthy as a household. Within the home, within the family unit, if people are losing jobs and families are struggling to make ends meet, it just raises the stress level. It also can exacerbate, the need to cope, and sometimes unhealthy coping will take the place of healthy, coping when things are stressful. So that could include alcohol use. And we know that intimate partner violence is associated with having access to a firearm in the home, high alcohol and drug use. And during COVID-19, because people were kind of forced to be within a space that may or may not have already been healthy, levels of violence may have increased. And we know that the numbers of calls for intimate partner violence have decreased in some jurisdictions, leading people to think that there's less of an ability for people to call for help because there's limited opportunity to be alone and have to preserve safety. And there's also fewer opportunities to actually leave and find respite in going to the grocery store, going to a doctor's appointment, or taking the children to school. So COVID-19 kind of exacerbated some of those conditions.
Thank you. That was a really comprehensive picture of how all these systems work together to kind of create this racism and discrimination that we see in the Black community, from housing to employment, family structure, education. So thank you for providing that information. So taking into consideration these health disparities and the reasons behind them, what can policymakers do to help African Americans and the African American community during the different phases of COVID-19, as well as looking further into the future?
I think that, in the past decades, researchers have done a really good job of developing individual and family level interventions and policy level interventions just account for a very small portion of the interventions that will eliminate racial inequities. I think that a health for all approach to policymaking should really be taken into account. That could impact, care seeking behaviors. So that perhaps delayed care could prolong life. Perhaps people would seek care at an earlier stage when they're first seeing symptoms, rather than delaying it and worrying about how is this going to be paid for. It could also create a lighter burden on the healthcare system. If someone already has insurance and can show up earlier and we can treat them earlier, because we know that in advanced disease state, those ICU beds are just more costly. Another thing is, considering the wealth gap. Things such as updating the minimum wage, making sure that everyone has a living wage. Applying those wage requirements to people that are working in non-traditional industries, such as those where they make tips or they work in agriculture. Just federally, the minimum wage has not been updated so that it applies to people according to where they live and how they can survive as a family or as an individual. Some other policy, solutions can look at, how housing is affecting largely Black Americans. So they're moving to developing, low-income housing that is integrated within communities that have more resources, or by making space for families that make lower wages to live in communities where they can have access to good schools, have a grocery store that's close by, may even be able to live closer to work, could help with their health outcomes and decrease health disparities. You know, federal programs that really advocate for safe housing, you know, regulations for public housing and low-income housing that don't properly adjust for and or ensure that the environment is safe. We know that children and adults that are living with asthma and also living in poverty are facing enormous challenges, and that's even exacerbated in the face of COVID-19. If there's a lot of dust, a lot of pests that are not being eradicated or taken care of, mold, then that can really change the health outcomes that family can have. And so developing policies that address discrimination in hiring practices, so that includes not just getting people into the door and giving them the opportunity to go to apply to positions across the board, but once they're actually in the door, there should be policies that ensure that employees have the opportunity to increase their responsibilities, increase their wages while working within a company. And right now, there's not very many avenues in terms of protection from discrimination from an employer. Another thing, policy-wise, that's specific to COVID-19 is improving the public health workforce. The epidemiology of disease really should dictate how we practice and how we respond. So improving that public health workforce could really guide our ability to respond and be specific, develop specific interventions for Black communities that are experiencing disproportionate rates of infections as well as death. But in order to do that, the epidemiology really has to be tracked in a very careful and purposeful, intentional way. And right now, in our national system, we have varying ways that states are tracking the effects of COVID-19 on Black Americans. So it took many, many weeks before states even started disaggregating the data, so we didn't even know how it was affecting our communities in the first place, our communities as well as other communities. And to this day, it still varies in the data that we actually have in order to be able to respond adequately. We could use those data if we had, a federal response that, dictated that these data were disaggregated by, poverty, by race, by many other social determinants, by density of where people live. Then we could make really good sound decisions about where testing sites should be developed and implemented. The number of hospital beds. And they are using some of those data right now, but the current system for tracking still is dictated by how states want to capture those data. And so we have good data and not so good data in some places. So therefore we can't mount a more federal and systematic response that will ensure that Black Americans, no matter what state they live in, are receiving the same interventions as well as the same policy level solutions that they need.
Thank you for that. I was thinking as you were talking, it sounds like you're really interested in improving the communication between public health officials and those in the sciences and working with the data with the government. Do you think that would happen more so at the local and state level, or should it be a federal level policy and kind of assuring that accountability and communication?
Well, I mean, I think that we definitely need to improve that at the local and state level as well. But I think that we should work to bolster the federal systems for reporting those data out. So the communication needs to ensure that certain criteria and certain indicators are being followed and tracked. And then that means that all 50 states will have the same data. And then the federal, at the federal level, they will be able to aggregate it in a more sound manner.
I have a question about something you mentioned a little bit earlier on about racial bias in the healthcare system. And I'm wondering if you could just expand on that a little bit more, and then perhaps if there's any policy solutions you see in kind of alleviating that problem.
It's hard to find a policy solution for that. But I do think that there are some things that we could implement, such as, systematic racial bias training for all staff in hospitals, from entry-level staff to, physicians and nurses that are, working in a professional capacity.
And then do you have any other just thoughts on policy or anything else that you wanted to add before we wrap things up?
Ensure that healthcare, that systems and sectors that are addressing the violence that inevitably impacts 1 in 3 women's lives and 1 in 7 men in this country, to increase the resources that are available. And I think that if we had a robust system that was intersectoral, where, shelters, resource facilities, healthcare facilities were all integrated, then we would have the opportunity to, during a time of crisis like this, really make sure that we can invest in the health of women, men, and children who are experiencing violence. And I believe that at the local, the state, and the federal level, we could ensure that those systems are working together to ensure safety for families, and more resources towards the multi-sector approach to safety could really go a long way. We have to build our systems and ensure that we're constantly investing in our systems so that they work during a time of crisis like this.
Thank you, Dr. Alexander, for all your time and your insights. We've really enjoyed talking to you today.
Great.